Thank you, Paul, and thank you, Klaus, for the kind invitation and the honor of once again participating in this very special course. I'm going to share a few words with you about our research into the relationship between hypermobility and symptomatic hip dysplasia. And these disclosures have nothing to do with this talk. I want to just pause for a moment to acknowledge the passing of Renato Bombelli, who died on the 17th of February. I received a call from his daughter the next day to let me know. And of course, I had a long-standing, wonderful relationship with this man, and we'll miss him greatly. He died at the age of 97 in Legnano, Italy, Monday before last. He had a significant impact, especially in intertrochanteric osteotomy surgery, and I first read his book when I was a middle-level resident in Boston, and during free time would go to the library at the Mass General and read this book and was very impressed with these results, which were considered crazy by the mentors at the Mass General, who thought that total hip replacement had truly replaced the role of osteotomies. But fortunately, they were proven wrong over time, and he played a significant role in that defense of osteotomy, even in the face of arthritis with regard to valgus extension salvage osteotomies. Now, in passive absorptive lectures like this, it's been well studied that approximately 5% or less of the material that is presented is actually retained by the adult human brain. So that means that in a lecture of 40 slides, you may remember something in one or two of the slides. So let's be realistic about how much of this you're going to remember. So it's imperative upon a speaker in this situation to be as clear and concise as possible and to repeat the key points as much as possible so that there's some chance of retention. So let me start by asking everyone a question, because engagement of the audience is one of the ways to increase the level of retention. So let me ask you, and please be honest, how many of you take a history and do an exam for hypermobility or hyperlaxity in all new hip patients? Please raise your hands. I'm actually very impressed with that number. I think it's more than I would have expected, and I congratulate all of you who are doing that. Let me give you the conclusions of my talk right at the beginning, because retention is much higher on the front end of a talk before active daydreaming takes place. Okay. Hypermobility is much more common in DDH than with all other hip diagnoses. The assessment for hypermobility should become a routine part of our orthopedic evaluations, and women with hypermobility-related symptoms are often misdiagnosed and treated poorly by the medical profession. That being said, we can afford to take a few minutes out of the formal talk to reflect on the historical significance of this course. My first appearance at this course was in 1979 as a guest of Maurice Mueller, and that was before many of you in this room were even born. Now, the only one in this room who likely attended the earliest courses was Mike Millis, who started coming here in 1921. Okay. I then came on many occasions as a guest of Reinhold, including the wonderful honor of being guest of honor in 2004. And now we are in the Klaus Siebenrock era. And the depth and greatness of the entire faculty of this department, including those now working elsewhere or deceased, makes the University of Bern unique in the world as an institution of worldwide impact in hip surgery and hip preservation. It is an honor to be on the faculty of this special course, and none of us on the faculty takes this invitation lightly. And we're very happy to celebrate the special honor that is going to be accorded, and deservedly so, to Mike Millis, who is an American hero of hip preservation surgery. Now, Bern is a special place not only for excellence in hip surgery, but for the warmth of the friendships that develop over the years here And I want to thank Klaus for the extraordinary friendship that he has extended to me over the years. And this is a picture from last night at this magical time with the snow falling outside. It felt like Christmas or New Year's in Fairyland. It was a beautiful, beautiful evening with snow falling in the background. So the public image of the renowned Professor Siebenrock is like this, holding forth in a meeting, moderating, giving great lectures, doing live surgery, and running a very important department. But there is a darker side. As the residents and fellows see him. Okay, too bad we are not all in San Diego. The video is what was taken outside the hotel yesterday, and that's a scene from San Diego yesterday where it was 24.5 degrees. Okay. All right, now let's get a little more serious. Our goal is safe and effective surgery, which is now being done as an outpatient for PAOs in San Diego. Hypermobility of the soft tissues may be a significant and underappreciated factor in DDH and other orthopedic conditions. The cultural view of hypermobility is interesting. It's seen in an oddity or having special abilities, and there are clusters of hypermobility patients who are in Cirque du Soleil, in ballet, in gymnastics, in high platform diving, and other activities that are uniquely suited to someone who has special characteristics of joint flexibility. Most patients are women who are unfairly misdiagnosed with depression, hormone imbalance, hypochondriasis, chronic pain syndrome, chronic fatigue syndrome, exaggeration, somatization, and other conditions, all with very condescending implications. Rarely is underlying hypermobility ever considered. There's been an expanding consideration of phenotypes of hypermobility, largely attributed to the seminal work of Rodney Grahame, who was the founding rheumatologist of the London University Hypermobility Center, the first of its kind in the world. Hypermobility has many manifestations above and beyond the hip joint, and some of these are very significant with regard to the patients that we all take care of. Let me share some of the commonly associated secondary factors that I encounter in many of my patients. Number one, temporomandibular joint problems. Many of these patients can't chew gum because their jaw will snap. They can't eat hard food because they'll feel pain in their jaw. They are nearsighted. Almost 100% of patients with hypermobility are nearsighted for reasons that are not understood. Resting blood pressure is almost always low and becomes pathologic in the aftermath of spinal anesthesia, where orthostatic hypotension can be a significant impediment to early mobilization. There's an insensitivity to local anesthesia that's unique to hypermobile patients. Many of these patients will say that dental procedures are very uncomfortable for them because dentists don't realize that they have a 2 to 3x added requirement for dosing for effective numbing of the tissues. And this is important for us to understand, and I use dramatically higher doses than recommended in my perioperative injections for postoperative pain relief. Constipation is very common because the collagen of the skin and the joints is also shared with the bowel, and the bowel is simply not compliant. And when you add narcotics to the postoperative pain regimen, it can create very, very serious issues of postoperative constipation. That is one of the main reasons in the past, when we were using narcotics, we don't use them anymore, but when we were using narcotics, it was a principal reason for delay in discharge. And some patients were actually admitted to emergency rooms in the week following surgery because of constipation-related issues that were directly attributed to the underlying hypermobility, and they often have a frequent history of ankle sprains. This is a very typical presentation in my office. These patients are walking in all day long, demonstrating all the funny things they can do with their body, and they like to entertain me with the things that they can do. which are, interesting when they're young, but these are these special capabilities progress to fibromyalgia in middle age and lead to the mistreatment of these women by the largely male medical community. Epidemiology of hypermobility is interesting. This has nothing to do with the study. This is the background work that was done before the study. It's well established that it's more common in females, that it's more frequent to diagnose in younger patients. There are variation across races, but no strong evidence. And the overall incidence in studies varies from 2% to 57%, depending on the quality of the study and the ethnic background of the pool of patients studied. Our goal was to prospectively evaluate every new hip patient for the presence of underlying hypermobility over the course of several years. We included 5 diagnostic categories, including dysplasia, degenerative arthritis not associated with dysplasia, FAI, labral tear, and other or miscellaneous hip diagnosis. We used the Baton Physical Exam Score, which is 9 points, and I won't go over that now because it's too boring, and the Hakim Grahame history inventory, which captures hypermobility that may no longer be present because hypermobility decreases incrementally with age. We had 1,015 patients enrolled over a 4-year period, and the results of the population as a whole was 22% were positive by Baton, 40% by Hakim Grahame history, and 44.3% by either method. The prevalence by age was striking, with a significant decrease in the elucidation of hypermobility with increasing age. Here you can see a bar graph of the linear relationship between age and hypermobility. Gender was very significant, with female gender 2 to 3x more likely to have hypermobility than male. We had some interesting racial information, that there was a statistically significant decrease in Hispanics. There was a trend in African Americans towards being more hypermobile, but we did not have enough data in other racial groups to have information of significance, but we are studying the racial issue as we go forward. Now, the most important aspect of this study was an off-the-chart positivity of hypermobility in the dysplasia patients, which was dramatically higher than any other hip subgroup. And overall, there were 84% of the dysplasia patients were hypermobile, and you can see the bar graph here for the much higher Baton on the left-hand side. So the predictors of hypermobility were diagnosis of dysplasia, odds ratio 8.4, female gender 2 to 3x more likely to be hypermobile, age much more likely to be discernible in youth rather than in later in life, and race. Hispanics are less likely to be hypermobile than others, and African Americans had the highest prevalence of generalized joint hypermobility, but not to statistical significance because of insufficient numbers. So now let's go back to the conclusions again, which we went over right at the beginning, and hopefully these 3 points will be retained. 1, hypermobility is much more common in dysplasia than with all other hip diagnoses. Assessment for hypermobility should become a routine part of our orthopedic evaluations. Women with hypermobility-related symptoms are often misdiagnosed and treated poorly by the medical profession. Remember the associated issues: TMJ problems, nearsightedness, resting low blood pressure, insensitivity to local anesthetics, constipation, frequent ankle pains. Now, final question. How many of you will now take a history and do an exam for hypermobility for all your new hip patients? Hands up, please. Thank you. So I want to acknowledge research support from OREF and acknowledge all who contributed, especially Mike Muldoon, my colleague, who does all the hip arthroscopies in association with our combined PAO and our FAI work. Thank you very much.